Hello, everyone, and welcome. Thank you for joining Foley and Lardner for today's presentation. Before we get started on today's program, I would like to go over a few housekeeping items. Questions may be answered via the Q&A widget located on the left-hand side of your screen. Questions will be addressed throughout the program, time permitting. The webinar is being recorded for post-event viewing. If you experience technical difficulties, please refresh your browser or visit the webcast help guide on the bottom of your screen. And now I will turn it over to Larry Vernaglia to begin today's presentation. Larry, over to you.
Thanks very much, and good morning, everyone. Thanks for joining us from the Healthcare and Labor and Employment Practices at Foley and Lardner. I'd like to welcome all of you. And we're going to talk about a subject that's been occupying quite a bit of our time since November 4th, when the Biden administration rolled out two complementary mandatory vaccination policies. And we're going to talk about those two and the interplay between them. The first is the Centers for Medicare and Medicaid Services, or CMS, interim final rule with comment period, which we'll refer to as the IFC. This rule mandates vaccination for all staff at a variety of certified healthcare facilities participating in the Medicare and Medicaid programs. It covers 17 million workers at 76,000 facilities. Also on November 4th, OSHA, the Occupational Safety and Health Administration, issued the COVID-19 Vaccination and Testing Emergency Temporary Standard, which we'll call the ETS, and that mandates vaccination or weekly testing and masking for employers with 100 or more employees, and that'll cover 84 million workers. So a lot of businesses are thinking about these, and a number of them are thinking about the interplay between the two. This is in addition to and on top of existing OSHA guidance, a presidential executive order that mandates and addresses vaccination for federal employees and federal contractors, and a patchwork of state laws that mandate vaccination and or testing in various settings. So we wanted to have a conversation that addresses some of the key questions that those of us who are participants in the healthcare industry will have. And it's a very diverse set of players that are trying to implement these policies on a very short deadline. The goals are simple: protect patients and protect the workforce by getting as many people vaccinated as possible. And they set really short deadlines. December 6th for the start, and January 4th for completion of vaccinations. Let me, before we get into our questions, sort of set the table a little bit to make sure that everybody, including those who are not in the healthcare facility business, understand what we're talking about. So OSHA issued its ETS on Thursday the 4th, and it covered employers, and if you were covered by the ETS, you have to be in compliance by December 5th. The ETS allows covered employees to complete their respective vaccination regimens by January 4th, 2022. And so the testing requirements aren't going to be required until that time. Most employers are familiar with following OSHA standards. This is what you're used to. And OSHA has issued prior guidance this year that you already are looking at. But the interplay between the CMS rule introduces some concepts that may be unfamiliar to companies that are not directly regulated by CMS, and we wanted to talk to you about that. And that rule is the CMS, the IFC, which was also effective on November 5th. And what it did was it changed various conditions of participation. Those are also sometimes referred to as conditions for coverage or requirements for participation, depending on what kind of healthcare facility you're talking about. But they're various names for the same concept. These are the rules that a healthcare provider or supplier must satisfy to participate in the Medicare or Medicaid programs. These are rules that are enforced by surveyors, often the state survey agencies or accrediting bodies like the Joint Commission. They regulate the facilities themselves. They're not directly applicable to, they don't directly regulate the individuals working there, nor do they directly regulate the vendors or contractors doing business with those facilities. But these rules are mandatory, and providers and suppliers have to follow them if they want to remain participating in the Medicare or Medicaid programs. And that's really important for healthcare providers. There's 63 million Americans in Medicare and 76 million Americans who are covered beneficiaries under the Medicaid programs. So not being able to participate in them would be a death sentence for most healthcare providers. For certain providers, like nursing homes, there are also intermediate sanctions, short of being kicked out of the Medicare or Medicaid programs, such as civil money penalties or denial of payment for new admissions and other things that could be brought into play for a provider that's out of compliance with their conditions of participation. How do they interact? And how will we document those compliance issues? CMS and the Biden administration has said that the CMS rules take priority over other federal vaccination requirements, such as the executive order or the Osha ETS, if they apply, although we think that some additional clarity out of Washington would be helpful for you. The rules that we're relying on include the regulation itself, which is really only a couple of pages depending on each provider type, and then the preambles to the Osha rule and the CMS rule. There's also a set of frequently asked questions, or FAQs, which were updated as recently as last week, November 18th, and we can put the link to that in the chat window or circulate it later. So our group here at the firm, including my labor and employment friends, three of whom are with us today, John Litchfield, Carrie Hoffman, and Brooke Bollinger, are all with the labor and employment practice. Rachel Goodman, Kara Schoonover, and I are healthcare lawyers. And so we've been having these conversations since the rules came out, and we thought it'd be useful to have the conversation and answer a bunch of questions at the same time. Rachel and I would like to give the disclaimer that we're not real lawyers, we're healthcare lawyers, so when matters of labor and employment are coming up, we're going to rely on our friends from the labor and employment practice to talk about it. So as we said, the rules are in effect. The compliance dates are short. In the meantime, to nobody's surprise, litigation was filed to disrupt the implementation of both rules, and we will cover some of that at the end of our discussion, and it certainly adds to the excitement. We have your questions. We received several dozen questions as you registered, and we're going to try to address a number of them as we go, and you're also welcome to put questions in the Q&A field. We'll try to monitor them over the next hour together. But probably the first question that came out of the box for us, and then a number of you as well, relates to the challenges of implementing the rule as it applies to the staff. Which are the staff of the CMS rule that must be vaccinated? And the definition of staff in the CMS rule is significantly more expansive than just the employees of the facility, or even the more expansive definition of workforce that some of you might be familiar with under HIPAA. So let me just walk you through what that definition is in the CMS rule. These are the staff that must be vaccinated under the CMS rule. And again, unlike the Osha rule, there's no testing option for employees who don't want to be vaccinated if they are working in a certified facility. So I'm just going to take this out of the hospital condition of participation, but the policies are basically similar for all of them. So hospital staff who provide any care, treatment, or other services for the hospital and or its patients are included. This includes hospital employees, licensed practitioners, likely members of the medical staff, even if they're not employed, students, trainees, and volunteers, and also, and here's the big catch-all, individuals who provide care, treatment, or other services for the hospital and or its patients under contract or by other arrangement. And here come in all the contractors and vendors who, while maybe subject to the Osha rule, are going to be indirectly regulated through the CMS rule. The definition of staff has a couple of carve-outs, and they're pretty limited. They don't apply to staff who exclusively provide telehealth or telemedicine services outside of the hospital setting and who do not have any direct contact with patients and other staff of the hospital. And it also does not include staff who provide support services for the hospital that are performed exclusively outside the hospital setting and who do not have any direct contact with patients and other staff. It seems like those carve-outs are useful, but it becomes a bit Talmudic as we go through these rules to try to figure out which vendor staff are covered and which ones aren't. So let me turn over some of these questions to my colleague Rachel and ask, how are we now trying to draw the line between those who are covered and those who are not covered? One of the questions we received from one of our guests asked about hybrid employees and how to handle them. Rachel, take us through that. And you may be on mute, Rachel.
Good morning, everyone. I will first answer that question and then move on to discuss some other responses to questions related to facilities, as well as more on kind of the analysis for the staff and vendors that may make your lives a little easier, just give you some shortcuts. With respect to hybrid employees, the CMS actually gives a very good example, which is a employee that works both at an assisted living facility, which is not a regulated facility, as well as a skilled nursing facility. In that case, that would be, what one would coin as a hybrid staff member. And because the staff member has, as part of the staff of the regulated facility, then that will be enough to kind of dragnet them in and cause them to be subject to the vaccine mandate, even though they spend some portion of their time providing services at a non-regulated facility. To answer a few questions that came in quickly related to types of facilities that are covered, generally, as Larry said, these are facilities subject to survey and certification, and hospitals are among them ambulatory surgery centers, home health agencies. There's a list of about 19 or 20 of those. Specific questions we received related to imaging centers. Imaging centers themselves, to the extent they're an independent diagnostic testing facility or an IDTF, would not be directly covered under the rule. However, I'll point out that anyone that might work at the IDTF but also go on site to a hospital or other regulated facility may indirectly be covered and therefore be required by the hospital to have a vaccine in order to provide services there. We also received a question about nurse registries and whether
Rachel, before we go on, let's talk about that a little bit too. A lot of times hospitals will send their patients to outside providers or suppliers to receive services under arrangement, and imaging centers are exactly that type of place. So if the hospitals are sending an outpatient or an inpatient out over there for those services, I think that's going to capture that entire imaging center suite of employees.
Agreed. If the contract is with the entire imaging center to provide under arrangement services, then I think they would be considered part of the staff of the hospital and therefore be indirectly subject as a vendor of the hospital. So I couldn't agree more, Larry. We also received a question about nurse registries. This is a licensure type in Florida, and other states have something similar, and whether or not if it had independent contractors, they would be subject. In response to that question, nurse registries themselves are not directly regulated under this rule and would not be directly required to be mandated. However, to the extent that the independent contractors, and again, the CMS mandate applies to employees and independent contractors regardless of employment status. So unlike Osha, where when you're counting to 100, you're only looking at employees. That is not the case with CMS. But so for the nurse registry, these independent contractors, to the extent they're going on site at a skilled nursing facility, providing services through a home health agency, going on site to a hospital, would all be indirectly subject to the vaccine mandate. And what that means for the nurse registry and other employers in a similar situation, such as IDTFs, is that they have to determine whether or not they have sufficient staff to be able to continue providing services to hospitals that are subject to the mandate or other regulated facilities. We also received a question about CMHCs, community mental health centers. Those are a facility subject to survey and cert and therefore are directly regulated under the rule, and all of their staff and vendors would be subject to a vaccine mandate, and they would be required to have policies and procedures for ensuring such vaccinations. I should also point out that while the CMS vaccine mandate does not have a testing alternative in the same way that the ETS does, it does provide for exceptions that are permissible under federal law, under the ADA and other federal laws, including for disabilities, sincerely held religious beliefs, observances, or practices, or medical reasons. And there are also some carve-outs that relate to if you have had a medical treatment that requires the delay of vaccination, then you can be accepted for a short period of time. So dealing with these is one of the things that has to be in the policies and procedures of the facility, a process for how to process these. And we'll cover those. Carrie will cover these later. Back to kind of some easy pointers, or maybe not easy, but to make your lives easier, pointers with respect to who that comes within your facility as staff and others needs to be subject to the mandate either directly or indirectly. The first thing to dispense with immediately is that visitors are not subject to the mandate. Therefore, anyone that's coming into your premises that's visiting a patient would not be subject to the mandate and not be required to be vaccinated. With respect to staff, one test that we have come up with that helps you to kind of figure out which staff do and do not when we talk about that hybrid staff concept is, number one, the person must be staff of the facility. So actually be providing services for the facility, even if they're not on site. So that's number one of the tests. And they must come into contact with other facility staff or patients. So for instance, if the person is an employee at a related clinic that is not part of the facility, and is not considered part of the staff of the hospital, just because that person comes into contact with staff or patients of the regulated facility does not make them subject to the mandate. So that's an easy two-part test that you might want to look at when considering whether the staff should be subject. With respect to vendors, it is a bit more complicated. CMS in its preamble discussed various methods for determining which vendors should and should not be subject to the rule. And, ultimately they considered, if they come on site 1 week, at least 1 week or one time a week, that they'd be subject. They decided to assist with that, and that fewer visits could trigger. And they tell you to look to three kind of factors. The first one is the frequency of the presence, the services provided, and the proximity to patients and staff. So based on those three factors, basically each facility is going to have to come up with a workable approach for determining who does and does not need to be subject to the vaccine mandate. And we'll talk more in a moment about how to implement that. Just a couple of examples provided by CMS and that are also responsive to your questions. For an EMS provider, for instance, it's very fact sensitive. So to the extent that the EMS provider actually has a contract with the hospital or other facility and is providing services pursuant to that contract, then they would indirectly, the EMS providers would be indirectly subject to the vaccine mandate. If there is no specific arrangement, arguably they would not be. If pharmacy staff is coming on site at a skilled nursing facility, for instance, they likely would be if it was done with regularity. But CMS points out that something like a once a year elevator inspection, you would not be required to have a proof of vaccination for this one-time visit. However, you would need to put in place other safeguards such as masking, et cetera. Okay, so Larry, I'm going to hand it back to you to discuss some more about kind of does everyone in the treehouse need to be vaccinated? And some of the
and this is kind of the way we've been thinking about it. One of the most challenging aspects of the rule as it came out was, okay, we get that vendors who come on site and provide services for the hospital or other healthcare provider are going to need to follow the mandatory vaccination rule. And as you mentioned, Rachel, those rare one-off visits, like the guy who comes on to fix the HVAC every now and then, we can carve that person out. But those staff who do come on regularly and provide services to our patients or the hospital are unquestionably covered as individuals who provide care, treatment, or other services for the hospital and or its patients under contract or by other arrangement. The challenge has been, what happens when there's a group of employees who come from a vendor who were unquestionably covered, who then go back to the vendor's location, let's say to a treehouse where they all work together? Does the fact that those staff members are now interacting with other folks in the treehouse who work for the vendor require those other staff to be vaccinated? And we can imagine that being quite a challenge for a lot of the vendors out there. I think the better reading at this point is that the answer is no, that the other individuals in the treehouse who do not have direct contact with patients, even though they have direct contact with the other staff, namely the treehouse employees who come onto our site, I think that there's a good argument that the hospital would not need to mandate that all of those employees be vaccinated. And that makes good sense when you think about some of the large employers out there who serve as vendors, who may send people in to the OR or other settings. Unquestionably, those people will need to satisfy the hospital's infection control requirements, which is where these conditions of participation sit. But I think it would be too much at this point to say that you're required to mandate that all those other employees of the vendor be vaccinated. And I think there's good basis in the regulation itself to take that position. Do you agree with that, Rachel?
I agree with it completely, Larry.
And if CMS chooses to put more out into its guidance on that, they can do so. Curry, were you going to say something?
No, I think Rachel was.
I will jump right back in, which is to tell you folks a little bit about kind of what you need to be doing now to try and start complying, other than doing all the things to get your policies and procedures in place. In other words, what is enforcement going to look like, and where is CMS's oversight going to be, and how will it look? And that is, as Larry mentioned earlier, through inspections. And we will learn more, I think, in the coming weeks. There are interpretive guidelines for all of the conditions of participation. Under the rule, they promised that there will be new interpretive guidelines that are interpreting these particular rules. But we do already know through the FAQ as well as through the rule that at a minimum, you'll need to have your vaccine policies and procedures readily available for the inspector. You'll need to have the number of residents and staff with COVID-19 cases over the last 4 weeks readily available, as well as a list of all staff and their vaccination status. So those are the types of things that you're going to want. In addition to just implementing the policy and creating the policy, you're going to need to have a process for having all of these things close at hand for when either an accrediting agency or a CMS inspector comes on site in order for you to show compliance. A question that has come in related to the ETS that I will allow Carrie and John and Brooke to answer has to do with the longevity of the rule. But one thing I wanted to point out that's a stark contrast is that the CMS vaccine mandate does not have an expiration date. Instead, CMS has left it without an expiration date and has said that they will determine during the comment period whether or not they're going to come back and do final rulemaking to keep in place forever. However, they've indicated they do believe that it's going to be in place much longer than the public health emergency. So that's something for everyone to keep in mind as well. To the extent the CMS mandate is upheld, that it does appear that it's going to have some longevity and could surpass the longevity of the ETS. Before turning back to Larry and to cover 3 of our kind of specific topics that we want to cover, I want to answer a quick question, which is that there was a question about whether or not if someone has not received either a Johnson & Johnson dose or their first dose of a 2-part series by 12/6, whether or not that person needs to be terminated. Ultimately, the answer to that question is somewhat within the discretion of the facility, but that is definitely not the only option. By 12/6, it's not just that they need to have their vaccination in place. They could also be subject to and under consideration for an exemption, for one of those types of exemptions that I mentioned earlier. In that case, there may be an arguable way to have that person continue to provide services as long as certain precautions have been taken, such as masking. Other options would be moving someone to fully remote work, as well as put on some sort of leave, or just kind of changing their work role subject to labor and employment laws. To quickly cover 3 kind of specific things, I'll quickly cover all of them and let Larry add some color as well as answer some questions. The first is that we recommend that everyone with respect to vendors review existing contract provisions. So, does your contract currently allow you to impose this type of mandate on your vendors? If it doesn't, you may want to consider amending it, or at least look for language that would arguably allow you to take these actions. Second is whether or not you're going to have a separate vendor policy and what your considerations are. This would include whether or not the hospital or the facility itself is going to collect the documentation on the vendor's employees or rely on the contracted company, which vendors to include, which is what we've been discussing, and then whether or not certain vendors should be included as a vendor versus staff and be under a separate policy. The third issue is whether or not to impose the ETS or CMS rule, even if not directly regulated. So this is for medical practices, for instance, that are not directly regulated, but all of their physicians who may have staff privileges would be. Until, the last week or so, this is something that I believe a lot of non-regulated but indirectly regulated facilities were considering doing. However, in light of recent legislation that we'll discuss later, for certain states such as Florida, this has become more of a problematic question and may prevent certain non-regulated or indirectly regulated providers from choosing to voluntarily comply with the ETS because it could put them at odds under law. But Larry, I will pass it back to you to finish up our topic.
Well, I do want to spend a little time thinking about what contract provisions you ought to expect to see. They might be in the 4 corners of the contract, and they probably ought to be, but they might also be in an HR or a vendor policy, which required, what are the requirements or conditions of visitors who come on site, business invitees at the hospital. But I do believe that the way to handle these cops is to put them into your contract. And these aren't new applications. The conditions of participation have always imposed duties on providers to assure that their personnel, whether they are employees or contractors or others providing services under arrangements, comply with the conditions of participation. Indeed, the governing body COP, which is at 482.12, specifies that the governing body itself, the board of directors, must be responsible for services furnished in the hospital, whether or not they are furnished under contracts. The governing body must ensure that the contractor of services furnishes services that permit the hospital to comply with all applicable conditions of participation and standards of contracted services, and that the governing body must ensure that the services performed under a contract are provided in a safe and effective manner. How do they do that? Usually just by contract, requiring in the contract that the vendor will comply with all the policies and procedures of the hospital. Sometimes they'll spell out the corporate compliance plan or otherwise, but then you're allowed to update your policies without having to go get a new wet signature on a contract. So again, this might not be in the four corners of your document, but your policy will require you to have the vendors subject to it. I don't believe that the policy should require you to terminate these contracts, because you might not exactly have a termination right, but it will at least require you to make sure that non-vaccinated employees don't come on site and serve your clients. Your patients. We could talk a little about some of the documentation requirements. That's come up in a number of questions, both in our window today, but also in calls with our friends out there in the industry. And you mentioned a minute ago, Rachel, that a hospital might be reasonably relying on a vendor attesting that they have documented evidence of the vaccination in their employee files. Because there are some hospitals that, while thinking about this, are thinking that they may need to independently verify those documentations. I think you could make a credible distinction, by the way, between getting attestations from an employee herself that she's vaccinated, and I don't think a hospital should do that. I think a hospital should look at those actual pieces of evidence that are mentioned in the FAQ and in the preamble, which include the actual record of the vaccination card or a photograph of it, documentation of the vaccination from a healthcare provider, or looking at a state registry. I think those are required for your own employees. I wouldn't rely on an attestation for them. But with respect to staff that are coming in from a reputable outside organization, whether it's a large established vendor, whether it's another university or another healthcare provider, I think relying on them to attest that those vaccination records are in their files would be adequate. I acknowledge that that's not as clear as it could be in the FAQ. In fact, there was a FAQ on this point on the 18th. They asked the question, then they never really answered it, but I suspect they will. In fact, it kind of goes to the way conditions of participation work. They are telling providers to write policies and procedures to address these problems. And every hospital, every organization, every ambulatory surgery center is going to do it a little differently. And even in the preamble, CMS acknowledges that providers and suppliers have the flexibility to use appropriate tracking tools of their choice. And so I do think that at the end of the day, they're going to allow some flexibility for organizations to make rational decisions about these documents. Ultimately, though, the hospital and its governing body are fully responsible for it. So if you end up having a vendor who lied about the status of a patient's vaccination status or made an error, the hospital will likely be responsible for it in the end. So I think that's all the questions that we've had coming in right now for the health side. Rachel, unless there's a few more you think we ought to grab.
I think we should transition.
Yeah, me too. We can field more questions at the end, and I can stay a little longer if we want to. So maybe we turn it over to John. Have you joined us, John?
Yeah, I'm here, and I apologize for being a couple minutes late. As the lawyers on the phone know, it's things come up that you can't avoid. So, at any rate, Carrie and Brooke and I are going to talk a little bit about sort of the interplay between the OSHA ETS and the CMS rule. And one of the things that we sort of have started using in terms of our vernacular when we're discussing this with our clients is that the OSHA ETS really sets a floor for employers that fall within its purview. So those that are 100 or more employees. and we'll set aside for a minute anyway whether or not the ETS will actually become effective in the end. I think there's sort of a large question around that. But for now, in terms of healthcare providers trying to come into compliance with the CMS rule, we like to sort of consider the Osha rule as the floor from which everything should be based. And what I mean by that is there are sort of gaps between what CMS says in its rules with respect to certain employees and certain folks who come on site that Larry and Rachel talked about, and what you do with employees who may not otherwise fall within the CMS vaccination mandate. And so it really sort of depends, number one, on how big you are as an employer. Number two, whether the individuals that are working for you are actually employees under sort of, standard labor and employment practices. Some individuals will not be considered employees. I think I saw a question about whether independent contractors who are working for you are subject to the CMS rule, and that really falls within Larry and Rachel's purview. But in terms of the OSHA rule, no, an independent contractor would not fall within your obligation under the OSHA ETS. And so, to the extent
and they do fall into the CMS rule, though, but they do fall into the CMS rule. To your point,
yeah. And so that's why there's interesting sort of gaps that each of these rules fill. But starting with that OSHA floor is sort of a good way to look at it. The other piece of it is, employees who are working completely remotely will fall outside of OSHA's purview, but also fall outside of CMS's purview, as long as, as we talked about, they don't have regular consistent contact with patients or staff who are inside the hospital or other healthcare facilities. So those are just some sort of broad concepts with respect to sort of where OSHA fills in some of the gaps. Carrie, I don't know if you want to talk a little bit about, the floor that we set, and then we can get into sort of the religious and medical accommodations issues.
I think you've covered the floor. I think you've covered the floor fairly well. I'm happy to sort of bounce back and forth on accommodations. Yeah. I think that's sort of where we're going to see a lot of play. I don't think as employers we have a lot of concern about medical accommodations, meaning we're used to dealing with them on an interactive basis. We are used to employees coming to us and needing some type of medical accommodation. We usually have forms in place for it. We usually have a process in place for interacting about medical and disability related accommodations. I think what gets stickier for us as employers, both under the OSHA ETS as the floor and even under the CMS rule, is religious accommodations. Typically, in years past, we've been hands-off about religious accommodations, and they've mostly been things about, I need the Sabbath off, or I can't be involved in this particular aspect of work because of my religious beliefs, etc. And we haven't really challenged them as employers. So we don't really have a lot of experience in dealing with that, meaning at least in my practice, when someone claims religion, we usually say, okay, we'll work around it because it's a one-off situation. This issue under the CMS rules and under the OSHA rules requires us to determine if the belief is sincerely held. And that's difficult to do, meaning how am I going to say this employee's religious beliefs are sincerely held? And it's about asking questions to determine what other things this employee has done based on those religious beliefs. But again, looking at, and John, feel free to pump on in, which is people can find religion in new ways, meaning it's hard to question whether someone has made this up, if you will, based on avoiding a vaccine mandate, or if they've now found a new way to practice a religion that involves whatever it may involve. I know we've seen some seriously off-the-wall accommodation documentation from employees, at least with respect to the original OSHA ETS and why employees could not be vaccinated, that feel like people pulled it off the internet, for lack of a better way of describing it. It doesn't look very sincerely held, but it's still an uncomfortable place to be. It's not like with a disability accommodation where we're getting a form from a doctor and the doctor is saying, you know, Carrie Hoffman has this problem and this is the accommodation, or she can't do this, or needs this type of process put in place to enable her to work. We're not getting a priest or a rabbi to sign off on these kinds of sincerely held religious beliefs. That's not the way the process works. But getting the employee in a form that, you know, you are comfortable with to explain what sincerely held belief they have and why it prevents them from being vaccinated is a helpful tool to evaluate how sincerely held it is. And that's part of this problem, which is, go ahead, John.
I was just going to jump in and say there's sort of another piece to that as well that we always talk about. And one of the things that I've sort of had conversations with our clients about who are struggling with the question of, is this sincerely held, because it sure doesn't look like it is that, you know, 95, maybe even 99% of the time, it's really not worth digging in much deeper if an employee says their belief is sincerely held. But what is important is to force the employee to into that interactive process that you would under even a disability accommodation request in normal circumstances, is make them engage in that interactive process. Don't let them stonewall you, or if they do stonewall you, that's a good reason to deny the accommodation request without even questioning the sincerity itself. But generally speaking, when you get the information, as Carrie said, from an employee and you have a form that they fill out and they do actually respond, at the very least, you have documentation about what they represented to you as their employer. And they're expected to be honest in what they're telling you. And so later down the line, if you discover that there's some inconsistencies in what they told you on that form and what they truly are practicing or truly believe, however that may come up, you can go back to that form and point to it as a place where the employee may have been dishonest with you and take appropriate corrective action from there. And then that avoids the question about whether or not it's sincerely held altogether, because really and truly it comes down to, is the employee being honest with you, and are they engaging in that interactive process? And if they're doing both of those things, then there's not much of a basis for an employer to deny it or otherwise take corrective action. But if they're not engaging in either one of those things, or they give you misinformation, then you have better footing as an employer to take corrective action with drawing the ire of a claim of some sort.
And then big picture, these accommodation requests are supposed to be submitted to you all very quickly, meaning at least under the CMS rules, they have to be provided to you by the 5th of December, and we have to start making that decision. So the good news is you won't be dealing with them for terribly long, meaning they're not going to be rolling in the way they seem to be under the Osha rules, whether they apply or not. Another thing to start considering is, to the extent we're providing the accommodation to the employee based on religion or based on medical condition, falling back to the Osha ETS, which we all recognize we don't know what's going to happen with litigation-wise, as the floor, does that mean we should be implementing weekly testing for these workers? So to the extent they're coming in, should we be following the other parts of the OSHA rule with respect to these individuals? I think the better argument, if you will, from an employer standpoint is, to the extent I'm providing the accommodation, even though I'm required to under both OSHA and the CMS rule, is to default to some type of testing obligation to those workers.
Yeah. An ancillary piece to this, which a couple of questions have sort of maybe not asked this directly, but have at least hinted at it, is how, and this is really where the CMS healthcare piece overlaps with the employment piece, is how can a hospital, or should a hospital that has a vendor coming on site that is required to make sure that that vendor has vaccination, should that hospital allow for a medical or religious exemption for those people, even though those people are not the hospital's direct employees? And my answer to that is sort of, I guess it depends a little bit. The sort of baseline is, again, go back to the floor. Is that vendor your employee? And if not, you don't owe that person accommodations in the same way that you would an employee under the law. And so you may want to go back to your contract or your vendor point of contact and ask whether or not those employers are providing the reasonable accommodations and under what contexts. But you can, technically, in my mind, unless Larry, Rachel, or Carrie, or anybody else disagrees with me, If you have vendors coming on site, you can have a rule that says, I don't want anyone who has any type of accommodation coming on site. I only want fully vaccinated people. That's because they're not your employees. You can do that. Does anybody on the phone, I mean, Larry, Rachel, Carrie, do you disagree with that?
I agree with that. And in fact, we've received at least one question about whether we could rely on a vendor's granting of an exemption for religious or health reasons. And I think that the better approach for a hospital would be to not rely on that. As you said, John, I agree that you could say we only want vaccinated staff coming to our facility, but the conditions of participation include so much more documentation of the process for reviewing an exception request than, say, for example, just proving vaccination status, that a hospital could credibly say, we're only going to run with an accepted staff member if they go through our entire process individually, or don't give it to them at all. And again, the whole notion that you might choose to rely on the vendor documenting the vaccination status is not entirely clear in the rule. The rule does not explicitly say that, but I do think that there is a credible argument that a hospital could make in that they could rely on those third parties to make that attestation. And the reason I think that, by the way, is because the examples that included seeing the vaccination card also included you could get notice from a provider who provided the vaccination or from a state registry. And those are both sort of third-party sources, not an original source of the documentation of the vaccination status. That's how I get to that point.
Mm-hmm. Yeah, and I think that's an important aspect of it. And Larry, to your point, I hadn't really thought about it before, but from the administrative sort of ease process, it's a lot less paperwork if you just require your folks coming on site who are not your employees to be fully vaccinated.
Sure.
So something to consider from a business process perspective. Carrie, I'm sorry, I interrupted again, but I thought it was an important point to make.
Agreed. I did want to throw in one. So we did have a few questions pre-webinar about the Florida law and whether hospitals could follow the CMS regulations based in Florida. Again, the CMS rules, and I know Brooke is going to talk about this, and this may be a good segue, definitely preempt contradictory state law. And at least as of now, Florida has not issued an injunction against the CMS rules from going into effect. So I don't know if Brooke, you and Kara want to jump in.
Yes, I think Kara's going to take this first, and then I'll jump into the specifics.
Yeah, so we've been spending a lot of time talking today about federal law. But as Larry alluded to at the beginning of this presentation, there's a patchwork of state requirements going on. Some states have laws, executive orders, or pending bills that are different from the CMS mandate. And a lot of you are curious about how that works. As Brooke will talk about more, some states have created their own mandate requirements for healthcare providers. Some states have forbidden vaccination mandates for all employers, including healthcare employers. And other states have different allowance exceptions. And a lot of this will be playing out in court. So to give you guys a background of what CMS says about this, in the preamble, for those covered by the CMS mandate, CMS specifically states that it intended this mandate to preempt any inconsistent or conflicting state and local laws. And it says it has the right to do so because of the supremacy clause, and kind of leaves it as that. But it does give us some insight on what it thinks inconsistent or conflicting is. So kind of on the big picture mandate side, CMS specifically stated that this rule would preempt state laws that would prohibit covered employers from requiring their employees to be vaccinated for COVID-19. But then on the exemption side, as Rachel and Carrie already discussed, CMS exemptions are for medical and religious accommodations, and specifically said broader exemptions are inconsistent with the state mandate. And so while Brooke will talk next about the states that have kind of the broader exemptions, several of you have asked questions about the states that have narrow exemptions. For example, some states like Maine don't allow religious accommodations. And at this point, there's no clear answer on whether they're permissible for these types of narrow exemptions as they're working their way through the court systems. And from what we've seen, the courts aren't having a uniform answer here. So that's a bit of background on the CMS's stance on preemption. So I'm going to pass it to Brooke to first give a little distinction about where CMS and Osha preemption stand, and then she'll talk about the particular state laws.
Thanks, Kara. We had several questions about Florida specifically because of the broader exemption, so I'll jump forward first. And and kind of is in line with Texas as well. As Carrie stated earlier, Florida's law is conflicting because of the broader exemptions it allows, specifically, for example, the COVID-19 immunity exemption. Governor Abbott's executive order in Texas would be in conflict and preempted because it allows an exemption due to personal conscience. Utah is similar in that it allows an exemption due to personal belief. So any state laws that are allowing exemptions on someone's personal belief or personal choice would therein be exempted because they're broader exemptions than the CMS allows. There's also some legal challenges happening. The state of Florida filed suit seeking to enjoin the CMS rule, and the court denied the injunction. Texas also recently filed suit in the Northern District of Texas, and the preliminary injunction here is set for December 2nd. So we should see how that plays out soon. There are also two fairly large cases happening. One is pending in the Eastern District of Missouri, whereas 10 states filed suit against the CMS. The briefing is due actually today and tomorrow. That appeals process would eventually play out in the 8th Circuit. There are also an additional set of 12 states that filed suit against the CMS rule in the Western District of Louisiana. And that appeal would obviously take place in the 5th Circuit, likely why they chose that venue, as the 5th Circuit recently enjoined the Osha ETS rule. So that should also be interesting how that plays out. Kara, I don't know if you wanted to go into anything else, legal challenges or state-wise, or if Carrie, you wanted to jump in.
Yeah, I think one thing to point out is there are some states that have already gone ahead with the vaccine mandates prior to the CMS rule. For example, Colorado already required any Colorado licensed healthcare facility to be vaccinated by October 31st. And so while there are some different or conflicting laws, there are also some that have already been in place that don't conflict with CMS. And so it's important to not only follow what CMS says, but what your state does that it isn't conflicting, which may be a hard decision to come to.
Yeah, and I think, from my perspective, one other thing just to point out on the state sort of conflicts issue is a lot of this stuff is as Brooke and Kara pointed out, being worked out through the court system. And I know that doesn't provide us any good solid answers at this point, which is unfortunate, especially in states like Texas and Florida. But really the important thing, and a couple of us were talking about this earlier today, the important thing is to weigh the business risks on each side of it, right? So if you're trying to impose a vaccine mandate that is limited with its accommodations to people who have medical and religious accommodation requests, and not extend, because that's what the CMS rule and what Osha allow, and not extend those accommodation requests to the broader swath of people who are covered under Florida's rule, then you can do that. The question will be whether or not, when this all sort of works its way through the systems, how it'll ultimately be determined. But the ultimate business decision in the short term is going to be dependent on whether you're willing to take a risk of certain claims being brought by employees versus, losing your either certification or funding or whatever the case may be by not being compliant with the CMS rule. Those are challenging choices to make. And I think that's going to have to be a very frank discussion with business folks as well as your legal counsel about what the best solution is, where we see things going, and what the ultimate outcomes will be. But also, and this has been the theme throughout the entire pandemic, is remaining nimble and ready to change on a dime, because as you know, these rules not only come fast and furious, but so do the injunction that we've seen in place on some of them. So being flexible is the name of the game. I know that's a tall order, especially for large enterprises, but it really is going to help you sort of, I think, get through this in the end to the extent that you can be as flexible as possible.
And I think we talked about this earlier too, which is when you're talking about the employment claims, looking at whether you have employment practices liability insurance, looking at that policy and making a decision as to those cost benefit analyses, meaning if we're intentionally avoiding and providing accommodations to comply with rules like the CMS, Are we therefore not covered by our EPL? And having those very open conversations, both within your HR team, within your executive team, and making really informed and frankly difficult to make decisions over the next few weeks as we work our way, because even though the courts seem to be very active, they also don't seem to be moving very quickly. In other words, we have a lot of litigation, but even the Osha ETS litigation that's been consolidated in the Sixth Circuit, they still haven't decided if they're first hearing it en banc or not. So we don't really even know where we're going to be and when we're going to be there with respect to the ongoing litigation.
Yeah. The other piece of this, and somebody asked this question in the chat box, and I think it's a good one, but the other thing to consider is at what point do accommodation requests, either whether they're medical or religious, become an undue burden. And essentially, you can no longer sort of operate in a safe way or provide your patients with adequate care if you're providing too many accommodations, or if the accommodations on an individualized basis pose some sort of an undue burden on the employer. It's a really good question, and it's not an easy one to answer on the religious accommodation side, because it really hasn't been worked out through jurisprudence or under the EEOC's guidance to date. And this is, partly due to the fact that, as Carrie mentioned earlier, religious accommodation requests were really rare until recently. But one thing to note is accommodation requests for medical reasons are governed by the ADA. Accommodation requests for religious accommodations are governed by Title VII. And even though they have a very similar process for determining whether or not to grant an accommodation request, there is a difference in what an undue burden is under both of those standards. Under a medical accommodation request, under the ADA, the undue burden has to be significant, right, in order for an employer to decline to provide an accommodation, meaning it has to have a significant financial impact on an organization or cause a true disruption, or I forget the exact statutory language at the moment, but a true disruption to the regular operations of the enterprise in order to be considered an undue burden on the employer. That's a very high threshold to meet, and most employers don't even go down that route when they're providing a medical accommodation in a typical context. That same standard doesn't translate to a religious accommodation request. What the courts and what the EEOC have said historically is that a de minimis burden is enough. Something more than de minimis is enough to decline it in terms of a religious accommodation request. So that gives you more flexibility with folks who have those religious accommodation requests to either deny them in the healthcare setting because they pose too big a risk to your operations and the safety and health of your patients, or if there's too many of them, the same answer would apply. I'd really urge you to talk to your legal counsel before making that determination, but it is at least an avenue for you to push back, not on the sincerity of the person's belief again, but more on whether or not it poses an undue burden such that you can avail yourself of that defense.
John, and your answer to that question also, I'm sorry, Carrie, I just wanted to add to what John's saying, that provides even more support to the analysis that the provider itself should run the request for an exception through its own processes, because what might be an undue burden to a medical device company for some employee working on the floor there could be very different when that employee is in the OR with patients and providers.
That's right. That's right. And that's, one of the things that we didn't really touch on because we just don't have time, is that each of these requests are required to be done on an individualized basis. You can't make a blanket determination across the board and meet your legal obligations one way or the other. So to Larry's point, there are different positions that may pose a more significant burden on an employer than others. And so you really need to look at the job that's in question, the individual's particular request, and then make an individualized assessment from there whether or not you can provide that accommodation. And that's true for either a medical or religious accommodation request.
But even with that, with the pending deadline to make those requests at the end of the first week in December, means you're going to have to wait to see all of them to make that cumulative assessment, at least on religion, to determine undue burden. Meaning it's not every time. You might have to look at each of them individually, but if you're going to claim we have too many people in widget making that affect healthcare, and I'm making up a term, obviously, but if you're going to make that decision, you need to know what the cumulative looks like. Is it, by facility? Is it by job title? And make an informed analysis as to whether that's an undue burden based on undue hardship based on the cumulative effect of it.
Right. Carrie, there was a question, and I'm going to read it to you because I actually think it's a good one as well. And it relates to collective bargaining. And it says, as the mandates effectively create a new condition of employment that was never negotiated under any CBA, how do you feel the healthcare union employees will respond? And do you feel there will be time given to negotiate new provisions? What's your sense on that?
I mean, my sense on that was that I don't have a choice but to comply with the law. So I don't know that I can negotiate anything more than how it's going to be implemented. Meaning, if assuming the CMS rule holds up, I have no option but to comply with the law. And I think I'm bargaining over the effects of it as opposed to the condition of it. But I'm interested for your thoughts.
Yeah, I mean, that's sort of how I'm reading it too. And I think it's a little different in my mind than a non-healthcare setting, because in a non-healthcare setting, the Osha rule is a little bit more flexible than CMS in terms of allowing a testing option versus mandating vaccines. Right. Even for people who don't have religious accommodation or medical accommodation. So, right. So I think you're right. I think it's more of an effects scenario than it is a condition scenario.
And I think it's letting the union know we're complying with the CMS rule as it stands because there's nothing enjoining it. And if you want to come to the table and talk about something, we're happy to do it, but this is what we're doing.
Mm-hmm.
For hospitals that feel that they are between a rock and a hard place on that, though, I would be certainly addressing that in your policies and procedures. If you know you have a CBA that's going to make it difficult for you to meet your compliance deadlines, you may want to treat that as a contingency plan. Rachel mentioned in her remarks that the conditions of participation are requiring contingency plans for staff who are not fully vaccinated for COVID. I suspect that if you know that that's going to be a problem for your organization, put that explicitly into the policy.
And I think that's something you could bargain over, meaning what's going to happen to the individuals who cannot be fully vaccinated for whatever reason. But compliance with the law, I don't think is something we have to bargain over.
And I would add to Larry's remarks that this contingency planning language that's in the rule is fairly vague. I mean, it makes clear that someone, for instance, that is a new employee that comes in after December 5th, which is, the initial phase 1 deadline for the CMS rule, they need to either obtain their first vaccine or, before they can treat patients, as well as have masking in place. So that would be a specific contingency plan example that CMS provides, but it becomes more unclear when someone, for instance, is, as I was discussing, awaiting a decision on their religious exemption, whether or not masking, for instance, is an appropriate contingency plan. So there is, a little bit of lack of specificity on what they mean by contingency planning, but I also think that it gives some flexibility for hospitals and other regulated facilities to act reasonably, as long as they've given thought to why they're taking a particular approach with respect to contingency planning.
And I don't think these COPs are really meant to be gotcha rules. I think that CMS put them out quickly. They're trying to address the industry's concerns. And remember, they're going to be enforced by surveyors who are going to have their own instructions. There will be survey guidelines that are issued under the State Operations Manual, Appendix A, for the hospitals. And that'll tell surveyors how to interpret some of these regulations. So I think there's still to be more guidance coming out of CMS that'll be useful for the industry.
And Larry, you brought up an important point that I think everyone on this call should maybe be comforted by, although you never want to have a deficiency when you're inspected, which is, for the vast majority of regulated facilities, they will have an opportunity to cure any deficiency. So if you're inspected, there's a deficiency under the conditions of participation, you will have for the most part, have an opportunity to cure. And so that should also give you some, relief in that there won't be, as Larry said, an immediate gotcha. I also, have seen in the FAQs and other documentation that it is not CMS's intention for this to be a gotcha or to cause people to lose their Medicare enrollment. That would be a very last, step after, various levels of enforcement and non-compliance has occurred.
And I think in these areas of line drawing, in gray areas, you are going to be given a little more leeway. Although the surveys for infection control at the long-term care facility level have been quite harsh, I should say, in certain markets and areas. So probably in the long-term care space, there might be a little less flexibility by the surveyors. And I certainly think that the immediate jeopardies are going to be reserved for those dramatic lack of compliance scenarios and not these potential line drawings that reasonable minds might have differed on. But that's just my guess.
Agreed.
We've come to the end of our time, I think. We have a number of questions that have come in as well. Carrie, what's your vote on sort of wrapping up and trying to respond to the questions or getting a few more in?
I'm fine if you want to take a few more. They're the ones that at least employment related, about pregnancy as an exemption. I think that's really a medical disability situation, meaning I think you might have to accommodate it if somebody tells you their doctor says they can't be vaccinated due to their pregnancy. But I don't think there's a specific exemption on pregnancy. John, if you know of one, let me know. But I would assume that's just a disability related situation.
I agree, but the one difference between that and sort of a typical, medical or disability request is that a pregnancy is only for 9+ months. It's not a never-ending.
It doesn't feel temporary when you experience it, but I agree it is temporary, and at some point they would have to go get vaccinated. That's
right, and so there is a point at which an employer can actually go back and ask for recertification. Interestingly, we've seen a couple of accommodation requests come through for people who are trying to get pregnant. Physicians and their medical providers are largely unwilling to provide support for that. And so if you get an accommodation request with some certification from a physician that says that, Susie Q asked me to provide this documentation, they're trying to get pregnant, oftentimes it will say, there's no medical reason why they should not be getting the vaccine. That's not a accommodation request that's supported by medical documentation, so you can actually decline something like that. We've seen quite a few of those come through. There are providers that will provide, the actual support for that accommodation request, but it is interesting the large number of those we've seen. And that's a place where you can push back.
And then,
one of the questions we had asked a detail on the surveyors who might be in there. And the question is, are the surveyors going to be private contractors like RAC auditors, recovery audit contractors, or CMS personnel? And the answer is that the surveyors are going to be very often state health department employees who routinely survey healthcare facilities. And they might also be surveyors who work for accrediting organizations who come in to provide deemed status surveys for hospitals and others, like the Joint Commission. This is not a billing rule. It's not a payment rule. It's a condition of participation. So I don't see this as within the purview of the RACs. Although you can never tell what a whistleblower might choose to do with these kinds of issues. But right now, it's a traditional health facility survey. Rachel, were you going to jump on one of the questions as well?
Yeah, there was a question that came in that asked about, and I think we covered this quickly, so I wanted to hit it again, which is for physicians' offices that are not regulated by CMS, if physicians who see patients at the hospital then see patients in the office on certain days, would that extend the IFR requirements to that office? And that goes back to Larry's treehouse analogy. And our reading as of now, without further clarification from CMS, is that if that physician's office is not considered part of a regulated facility, then only those staff that work for the physician's office that also come into contact with patients and staff at a regulated facility would be required to be vaccinated, but it would not create this cloud of vaccination mandate over the entire physician's office. So that's one that I think has come up more than any other question. And this blurring of the lines of whether or not, one person can trigger everyone to have to be vaccinated in a non-regulated facility. My interpretation is that the answer as of now remains no.
There was one question on hiring, which I think is an interesting question, and whether, as a vendor, if you don't have a mandatory vaccine policy, but you supply employees and you have an open position for someone who would be going on site to a provider that would mandate vaccines, can you basically not hire that person on that basis? The answer is probably yes. I mean, you do have, sort of the standard accommodation considerations to consider, but before you do any of that, somebody has to be qualified for the job that they're actually applying for. And if one of the qualifications is that they need to be vaccinated, and it's not your requirement, but it's your vendor's requirement, that's an objective qualification that someone who's applying for that position can't meet. And so I think you have a legitimate reason to not hire that person on that basis, even if as an employer, you would otherwise have to provide a reasonable accommodation. But if you don't, if they're applying for a position that is open and there's no other openings that they're qualified for, and that's one of the requirements, I mean, Carrie or Brooke, unless you disagree with me, I think that's an objective reason not to hire that person. Sounds like they agree.
Sorry, I was on mute. I would say big picture, doesn't mean they can't check a box on an EEOC form, but I agree that I think they're not qualified for the position, and that's the defense you would take if they did that.
Yeah. It's different if an employer or if if the hospital that you're going to is requiring you to do something that's illegal, right? That's sort of a different question, but they're not requiring you to do something illegal. They're requiring you to do something because they are required by the law to do it, right? And so, so the answer would be different if they asked you to, never hire anybody who has any type of disability at all, and there's no reasonable basis for that. But in this case, no, I think that's the right answer.
We have really come to the end of our time. We tried to field another couple of questions. The last one that somebody has asked is, is it true that there's no injunction of the CMS rule as of this date? And as we sat down to our computer, I do not believe that there is an injunction of the CMS rule. I think it's in effect today. I think those two compliance dates are coming really fast right after the holidays. So those of you who are in a certified facility, I think you should be absolutely moving to get your compliance done. And if you're as a vendor, doing business with those facilities, hospitals, nursing homes, and others, I would be expecting that those would go into effect. Keep your eye on our healthcarelawtoday.com blog, and we will provide updates if there are any. But with that, I think we've come to the end of our time. I want to thank my colleagues, particularly from the labor and employment side, and my sisters in the health practice. Thank you for being with us all today. We'll try to respond to your other questions. If anything else comes up, you're welcome to email any of us, and we'll try to get back to you. Thanks for spending your morning with us.
Thank you.
Thanks.